in the session on training of the trainers. So I'm going to talk about how do we enhance the surgical prowess through camp activities. So but the term, it's not moving, slides. If you look at the meaning of the word prowess, it means ability, expertise, proficiency, but the actual meaning is exceptional skill. But for today's conversation, for this talk, I'll probably use the word competency. If you look at the need, why do we need to enhance the surgical competence? It's a need of the hour, because there are several community-based surveys have been done on blindness, which had shown that the poor surgical outcome and inadequate access is one of the major causes for reducing the blindness due to cataract surgery, especially in low resource setting. If the surgical outcome is poor, and that is also going to bring down the trust of the community on cataract surgery. It's not just going to affect only the community-based intervention, but it can probably affect the whole eye care as it is. Because we have seen, whenever there has been a kind of outbreak of cluster infections in a particular state, particular area, whole state, the surgical volumes come down. So it's very important that we improve the surgical competence. It's very, very important. And again, these studies which have been done in several countries in India, Asia, and elsewhere have said that in order to address this backlog due to blindness due to backlog of cataract surgery, it's important that we train additional surgeons and also provide them with the appropriate equipment so as to address the question of access. Sometimes patients come, but the equipments are not there, the trained people are not there. But they also say that if we have to really succeed, we have to monitor the quality. So having trained the surgeon, the equipment alone is not enough, but the quality is also very, very important. All this have come out of the several studies. So the volume really gives, because once you have the volume, the residents are able to operate more number of surgeries, their manual dexterity improves. That's very, very important. The volume is what it does. So people talk about, even the students talk about the volume. That is where the manual dexterity improves, which in turn improves the surgical skill, which in turn helps to bring down the surgical complications. And again, Prasha, when Dr. Gogate spoke about, he was talking about the exact correct volume which we need to have to reduce the complications. So this is, I'm just sharing this particular study we published from Ravindran of 38 postgraduates, both who joined for MS and DO for 2 subsequent years. And then the next 4 years we tracked of about 13,000 surgeries. As you can see in the first year, the first 100 surgeries, it's not working, so. Yeah, so if you see the first 100 surgeries, the intraoperative complication, which is the first bar, it's about 4.14%. The second bar is about the post-operative complication, it is 2.3%. And the resurgery is the last bar, so 1.46%. This is what we saw in the first 100 surgeries. As you can see, that number drops as the volume of surgery increases. When it goes beyond 300 surgeries, now the complication rates drops to about 1.94%. But the minute they cross about 600 surgeries, the complication rate drops to close to about 1%. So the volume plays a much, much larger role. And at least, from the study, we feel that at least residents should do about at least 300 surgeries to bring down the complication rate to less than 2%. And the number of free patients who come into the hospital and again through the camp or the outreach, which is today's talk, is really important if you want to give the volume to the residents and the fellows. But what is really important, before you have to give the volume to the residents, is very, very important that give them the foundation. A structured surgical training program, the first 18 months is very, very important. Through wet lab, we heard Dr. Titial talk about it. Training by dedicated trainers, having a proper protocols, all of that becomes very important. So in our institution, at least, we start the PG's surgical training, especially the wet lab, the 5th month, for the fellows who people who join as fellowship at the 3rd month. And once we train them through the wet lab, both with the simulator, with the animal eyes, with the dry wet labs, we move them to the surgical training. They start with the manual small incision cataract surgery. I mean, the way we train them is we train them intensely for a period of 1 month. Every day, the resident or PG or the fellow will go to the operating room with that month of surgical training. But the very first day, they just do only one step, maybe in 3 or 4 patients. Second day, they do the additional step, maybe another 3 or 4 patients. By the end of that 1 week, they are able to do all these steps. When they come to all steps, then they probably operate on only one patient. And as a result of this, we don't have to supervise them constantly through the next 3 years. If you are able to concentrate on mentoring them for the next 2 months, it's enough, and they become independent to operate on the 6th to 8th month. But what is important is you must have a dedicated trainer. We have a trainer who sits with them for the whole day. The trainee also got nothing else to do other than operating and watching other surgeries, and also the mentor will also sit with them and go through all the post-operative evaluation. And again, once you have such a kind of a dedicated trainer, then monitoring assessment through logbook, all of that becomes much easier. And we have a proper rubrics for assessment, and we also have a weekly audit of all the surgeries, including all the complications. And as a part of this program, we also teach them how to manage complications, probably at the 18th month. So this prepares a person for doing a high volume. So that preparation, the foundation is very, very important. Now once we also expose them to the camp, they also have an opportunity to understand the need of the community. They also understand the challenges faced by the patient to access the eye care services. And again, when they are involved in the eye camp, they have to go to the camp and see the patients, use basic equipments like torch to identify patients for cataract surgery. Their clinical acumen also improves. They are able to understand the importance of visual criteria for selection of the patients for surgery. They are able to understand the impact of the systemic diseases. So all that helps in improving the decision-making skills. So when this is combined with rescreening base hospital, these same residents, same fellow, the patient, they have seen them in the camp. If they are able to see them in the base hospital, see them with the better equipment, they are able to coordinate with the cataract changes and the visual thing. So all this have to be a part. And again, once you want to train them in a volume, probably you have to provide them 2 tables, so they are able to operate large volumes. And again, what is important, this trainee also has to become a trainer at some point of time. The 2 years of fellowship or 3 years of residence, at least 1 month they play the role of a trainer when they become a senior postgraduate. So as a result, our fellows and the residents contribute to nearly 40% of the manual small incision cataract surgeries that are done. This I want to share here. So if you can see with the months of training and the volume of surgery, their complication rates also drops to close to around 1%. But as you see here, by 12 months it really drops, again it goes up, because until that point of time, they may not be doing complex surgeries or high-risk surgeries. When they start doing those complex high-risk surgery, again probably it goes up, but doesn't really go. If you look at only the normal surgery, it will be definitely much lower. But if you see the bottom, when there is the 3rd month or 4th month, the complication rates are about 6 or 7. So to conclude, exposing surgeons to high volume surgery makes them confident. They are also, when it is done through a camp, they are able to understand the importance of community outreach. They are also aware of the role played by the paramedical staff, and they are also able to develop the leadership skills, which help them in their practice later on. But the key to all the success is the adequate pre-surgical training, learning in a step pattern, close faculty supervision, and opportunity to play the role of a trainer. I mean, they're very, very important. If they play the role of a trainer, they really learn a lot. That is really probably the foundation. First 18 months, and being a trainer is very, very important if you want to make somebody a very competent surgeon. Thank you.
Thank you, Dr. Ravindran. It was really very beautifully outlined how important structure is to a training and how structure provides discipline to surgical training. And making them trainer adds a certain sense of responsibility to them, which goes a long way. I just have one question, that there is an immense divide when it comes to different regions in the country. The amount of volume which residents or fellows get to train surgically down south is way more than what they get up north. So is there a way that we can address this issue in future? Because there is no way a resident in a North Indian medical college or even in a Premier Institute gets to do a 600 or 600 plus cataract surgery or so. So is there a way that we can come somewhere to a middle ground to address this issue? Thank you, sir.
I mean, it's all about it's all about science. It's all about commitment. I mean, I think every institution should be able to do it, because we have worked with nearly about 350 eye hospitals across the country, and we were able to do that in about 90% of the hospitals, where their volume became doubled in a period of 2 years. So I think increasing the volume is also about a science, and it's also there's a way to do it. I think it can be done.
And you told about the paramedical. I think in the whole country I haven't seen such disciplined paramedical as you are having.
Yeah.
That also adds to the efficiency of the
if you want to do the volume,
that we are lacking in North.
Yeah, which we cannot
only
do.
at my place.
Now, once you have the paramedical, then you can take away many of the work that is being done by the doctors and the surgeons or the postgraduate fellows, which need not be done by them. So then the role they can play also becomes much more well defined.
Ravindran sir, just a quick question before we move on to the next session. A lot of challenges are being faced now in conducting the camps. If you're aware, in Karnataka itself, now they have brought a slab where you can't operate more than these cases in these many districts under DBCS. Second thing is, you need to have a complete set of team, as said, led by the Supreme Court ruling, that you have to have an anesthetist, you have to have a physician and all those things, and show them. Third thing is, all the camps should be conducted near the PHC. Fourth thing is, the post-op also has to be seen there, is because the people come, do and go. Where should the patients go for post-op? Is the question which is being led nowadays. Fifth question is, now they are asking to do it's called as KPME, I don't know what is in other states, where we need to have all the authority, like running a hospital. Even for the vision centers, now we have to take the certification to do a door-to-door screening. So a lot of challenges now is being put forth by the government now. So how is it in Tamil Nadu? Is it the same, or you have found out a way how to solve these problems without disturbing the governmental regulations?
Fortunately, in Tamil Nadu, we work very closely with the government. Government is very supportive. I mean, it's also about advocacy. I mean, in the sense, we involve the community quite a lot. So we don't do any ICAP on our own. It's always a Lions or a Rotary or a community organization who runs a camp. So if there is a problem from the government, these community organizations will go and speak for ourselves, or they'll speak for the community. So instead of putting us in the front, we put these community organizations saying that they want this to be done in their area, that all this regulation should not be there. So we also face a similar one in the districts, but
we allotted to each hospital.
no, it's not like that. So we sometimes that is put forward by the NGOs, but as a group of all the NGOs within Tamil Nadu, we all have told the district authorities and the state authorities saying that we don't want any division. We want independence to operate in all the districts. Don't divide us based on these districts. So it's a community collaborative work. It has to be done with the community and also with the government. So if there is a problem, if one is not there, then it's not going to happen. Otherwise, it's a very challenging. Doing community work is not easy.
That's the question.
It's very challenging. Unless you have the will and to do it, you cannot be able to do it.
Exactly. Thank you.
Just after one group photograph.
Yeah. Thank you.